triple negative breast cancer is defined by having the absence of markers rather than being positive for markers, which is already kind of an odd situation. And I think one of the things that really has been worked on is to try and categorize triple negative breast cancer a little bit more by looking at gene expression and gene expression patterns. And through those studies, we've been able to define different subsets of triple negative disease, but we haven't yet been able to make the leap of taking those subsets and selecting what the right treatment is. One area of great interest is trying to take the luminal, sort of more indolent subset of triple negative breast cancer that expresses the androgen receptor and treat it with androgen receptor antagonists. However, that's an area where we've seen very low response rates and really remains to be better defined. So it's kind of I think a hope that we might be able to do that rather than a reality. So other than that, the way we evaluate triple negative breast cancer is really by extent of disease and response to prior therapy, rather than by specific biomarkers that we're targeting with treatment. So what we have understood about triple negative disease, and understood more and more over the last few years, is that these cancers that are more rapidly proliferating have a better response to chemotherapy, but the response can be short-lived, and particularly as the cancer develops more and more resistance, it is more short-lived. So we do favor giving neoadjuvant chemotherapy for most triple negative breast cancers, except for the very small ones where we give chemotherapy in the adjuvant setting, but it's a rare patient with a triple negative cancer. It would have to be extremely small where we wouldn't consider some sort of chemotherapy in the curative setting. So then the question is what the optimal chemotherapy is, and a number of studies have looked at giving chemotherapy with docetaxel cyclophosphamide, the so-called TC regimen, versus an anthracycline taxane-based regimen, or more standard ACT type regimen, or TAC, what is all given together. Several studies have tried to look at this in a global population where you include ER-positive disease as well. In general, it appears that anthracycline regimens are superior to non-anthracycline regimens for most triple-negative breast cancer, and that the more intensive chemotherapy results in higher pathologic complete response rates. And in general, for an individual patient, getting a pathologic complete response, or at least close to it, classified as residual cancer burden 1, is associated with better outcome for those patients. So it's been a big driving goal. So in that general idea has been the approach in a research sense that maybe if you change the chemo, you would get a better response, and then more people would be cured of their early stage triple negative breast cancer. So one area of exploration has been adding platinums to chemotherapy and other agents as well. All the studies that have added a platinum, mostly carboplatin, to a standard anthracycline taxane-based chemotherapy have shown a higher pathologic complete response rate. One study suggested that in patients who got a taxane plus a platinum salt without an anthracycline, had a pathologic complete response, that they did extremely well. So that you could use this as a way to improve PCR rates in patients with slow responses, but also potentially in the future as a way to be able to select a group of patients who might be able to do well without anthracyclines. There's also been studies looking at the addition of PARP inhibitors in the neoadjuvant setting. Generally, the PARP inhibitor that's been studied the most is veliparib in that setting, and we haven't seen an improvement in PCR rates in the global triple negative population, nor when we've looked at the patients who have BRCA germline mutations. And it may be that carboplatin is powerful enough that the addition of veliparib can't overcome that, or that veliparib itself is a weaker PARP inhibitor, particularly at the doses given in these trials, and so it's not having that effect. But so far, we don't have any data that PARP inhibitors in that setting work in patients who have wild-type germline for BRCA1 and 2. So then the question is, what do you do for patients who don't have a pathologic complete response? And the study, I think, that made the biggest splash in that area, and certainly the only positive trial, was CREATE-X, that looked at capecitabine given for mostly 8 cycles versus no capecitabine in a group of patients who were randomized in Japan and Korea. And what they found was that overall, the study population that included patients with ER-positive disease had a better outcome. So they had less recurrence and better overall survival. But when they looked at the subset, they found that that difference was all in patients with ER-negative disease, so triple-negative breast cancer. So that now is published, and has become very much a standard of care for patients who have residual disease after a good anthracycline and taxane-based neoadjuvant chemotherapy. One question has come up: if a patient didn't get a platinum, should you give them a platinum? So there is a study going on that's now randomizing within our cooperative group in the U.S., run by, and the study is chaired by Ingrid Mayer, that's looking at giving a platinum, a physician choice, cisplatin or carboplatin versus capecitabine as a post-neoadjuvant treatment if you didn't give it up front. My general clinical approach is to start with a taxane and a poor responder to add platinum after 3 or 4 weeks to see whether or not I can improve the response. And then, of course, you follow it up with the anthracycline-based regimen, usually doxorubicin and cyclophosphamide. And then, so I think there's a couple of different ways to do that. In terms of what we do in the metastatic setting, triple-negative breast cancer is still an extremely difficult disease to treat, and there's a lot of interest in finding new drugs and improved methods of both assessing response and patients whose cancers will respond versus not, so prognostic and predictive indicators. Our focus has largely been on 2 broad areas. So one is immune checkpoint inhibitors that were started, their whole studies were started in triple-negative disease because this is the cancer that has more of an inflammatory infiltrate, referred to as tumor-infiltrating lymphocytes, higher expression of PD-L1, although I think that we don't know really that that has any correlation with response yet in breast cancer because the studies are conflicting. And also, it's a more rapidly growing tumor that already, before we understood tumor-infiltrating lymphocytes, had evidence of more of a host response. So the idea was that if you remove the checkpoint, the host response could then eliminate the cancer. So there's been a lot of interest in that, and checkpoint inhibitors have been studied in both the metastatic and a neoadjuvant setting. In the metastatic setting, so far what we've learned is that checkpoint inhibitors have a very low rate of response in a sort of overall triple-negative population after the first line of treatment. And we don't really know how that will play out when we start looking at different lines and different subsets, et cetera. But response rates are in the less than 5% range. But if you treat patients in the first-line setting, response rates are quite a bit higher, just below 25% in 2 different studies with 2 different checkpoint inhibitors, pembrolizumab and atezolizumab. And the response is correlated with tumor-infiltrating lymphocytes, both in the first-line and later-line settings. So that was very encouraging. Of course, the interest is now, why do we care about response when we don't use response in other studies? Well, it turns out that responders in general do very well. They stay on the therapy for a long time, and their overall survival is completely different from the other group of patients. So you're really selecting out a group of patients who you treat with these immune-directed therapies, and they can do extremely well compared to patients who just are in the sort of standard area or who don't respond to a checkpoint inhibitor. So the next step, of course, is the interest in combining checkpoint inhibitors with other drugs or approaches to treatment that might be able to improve the host immune response, and then the checkpoint inhibitor would work better. So a number of approaches have been taken. The giving chemotherapy, of course, is the simplest one. There's a phase 3 trial, 2 phase 3 trials that have completed accrual. One is expected with atezolizumab to report out later this year, and then the keynote trials with pembrolizumab at a later time period when they have enough events. There's also data from the preclinical setting showing that if you combine PARP inhibitors with checkpoint inhibitors, that you may enhance the host immune response with the PARP inhibitor. And so that's being studied as well with initial encouraging results, actually, and now needs to be tested in a randomized trial setting. Seems to be very well tolerated. The chemotherapy that's been added are mainly taxanes and also gemcitabine and carboplatin, but other chemotherapy agents like eribulin have also been tested, again, in single-arm phase 2 studies, and certainly it's tolerable. Another area that has been of interest is using other targeted agents like MEK inhibitors, where there's some preclinical data that there may be an enhancement of the immune response, and there's a lot of other targeted agents that are being studied. Immune agonists, for example, that target 4-1BB or OX40. Those are agents that are also being combined. So that'll, I think, be very interesting. There's interest in maybe radiating a single lesion, potentially causing an abscopal effect where you increase the host immune response. It's directed against those tumor antigens, and then it works in different areas of the body as well. Very early data with a little encouraging, few patients, so we'll see. There'll be more studies looking at that potentially in the neoadjuvant setting, which is interesting. And overall, I think the other idea is to try and treat patients who are earlier in the course of therapy because they're more likely to have an immune response. We've learned from a variety of studies that there are less TILs potentially in liver than other organs in particular, that you have less TILs as your cancer progresses, so less chance of responding. So there are neoadjuvant trials that have shown that it's safe to give the checkpoint inhibitor with chemotherapy. We do see some immune toxicities over time, but they're very treatable. And the I-SPY randomized phase 2 trial that's adaptively randomized, so it looks at the chance of PCR rather than actual numbers, showed that the possibility of PCR seemed to be tripled in the triple negative group when you added a checkpoint inhibitor, and almost tripled in the hormone receptor positive group. So that's very encouraging, and studies are ongoing within I-SPY looking at giving a checkpoint inhibitor and then not giving the anthracycline to see whether or not you need it. And there are randomized phase 3 trials being done with pembrolizumab and atezolizumab, and then some conflicting data using another checkpoint inhibitor, durvalumab. So I think that we're in an uncertain situation with checkpoint inhibitors in breast cancer. I think that where they're going to be successful is in combination. That we're hoping that we'll be able to develop the test of TILs, tumor infiltrating lymphocytes, that our colleagues have worked hard on and have demonstrated a lot of importance to use that in the clinic as a way of really assessing who's more likely to benefit from what combination or what approach. Obviously, this is still a little ways off, but I think it's very encouraging right now to see how we're going to do with different chemotherapy combinations, with different settings, and with different immune agonist type approaches. The other really exciting area is new targeted agents. So there have been a couple of studies that have looked at AKT inhibitors in combination with paclitaxel as first-line chemotherapy for metastatic triple-negative breast cancer, and both studies have shown some benefit in terms of progression-free survival, particularly in the patient population that have alterations in the PI3 kinase pathway, which makes a lot of sense, so PTEN, PI3 kinase, et cetera. And obviously we need randomized phase 3 trials because you don't know about phase 2 trials, but it certainly is quite encouraging to see two phase 2 trials that both have shown this improvement by adding the AKT inhibitor in patients who have altered their tumors, have alterations in this global pathway, not a single marker, but I like the idea of a global pathway. It's, I think, a much better way to look at it. So there is an ongoing phase 3 trial with ipatasertib, and then there's another AstraZeneca drug that will be studied as well. And then we have a whole group of drugs called antibody drug conjugates, where you have an antibody that's linked to a toxin. And this is a whole new exploding area where we've seen really impressive results with a drug called sacituzumab govitecan. And this drug actually targets TROP2, which is widely expressed with a metabolite of irinotecan called SN38. And the drug is given day 1 and day 8 every 3 weeks. Seems to be pretty well tolerated, mainly bone marrow suppression, and you lose hair. But the response rates in triple-negative breast cancer have been very, very impressive, higher than we've seen in many other settings, and drug well tolerated, and many people staying on, well over 30% response rates. And then they've also recently presented data that has shown that in a small group of patients with hormone receptor positive disease that the response rates are in the 30% range as well. It makes sense. TROP2 is expressed on ER positive disease, so potentially broadly applicable new cancer drug with very high responses, even in refractory disease. There are other antibody drug conjugates, one ladiratuzumab, which is a drug that targets an antigen called LIV1A and gives a microtubule toxin as the payload. And that drug is now being tested in moving into the phase 2 setting. They've seen some very nice phase 1 results. It's in our neoadjuvant I-SPY trial. It's being given in combination with a checkpoint inhibitor, and will move on in development. So that's an interesting drug. There was a third one called glembatumumab vedotin. That drug was in a randomized phase 3 trial called the METRIC trial, which was a negative study. Interestingly, they didn't really have a lot of data in the phase 2 study to move on to a phase 3 trial. So, it makes sense to me that potentially they didn't see that signal, although I'm still sure they're still looking for some signal with the drug in some setting. We haven't seen that data presented publicly yet. So all in all, there's really a lot of new agents being studied in triple negative disease and agents that we're hoping will be effective. At this meeting, we've seen at ASCO this year, we've seen some interesting data with antibody drug conjugates that have trastuzumab or HER2 targeting antibodies as backbones. And these drugs have actually noticed some pretty impressive responses, particularly trastuzumab DS8201, particularly impressive data in HER2 1 and 2 plus. And those tumors that are ER negative and HER2 1 and 2 plus are essentially triple negative. A lot of the patients had ER positive disease, so we don't yet know if those responses will be seen in a real triple negative population. You know, it's been just so interesting that breast cancer has lagged behind in the immuno-oncology world, but not unexpected. You know, breast cancer is not a very immunogenic cancer. It looks like self. And, you know, I always think about it as the cancers that responded to interferon respond to checkpoint inhibitors. You know, these are cancers that actually, you know, have a clear host immune response that is important to cancer outcome. And so we saw that when people responded to high-dose interferon. We saw it in the subsequent therapies. They're immunogenic cancers, and breast cancer just isn't. So, you know, we see response rates of some degree in almost all cancers. I don't think there's a cancer that has zero response. But the degree of response is very much determined by the amount that the cancer acts out, you know, looks different to the body. So I think the data on TILs are very exciting and pretty convincing. We've seen it now across a variety of trials, including in HER2 positive disease, and where immunotherapy is also being tested, where TILs really predicted response to immunotherapy. So, and also we've seen in the early stage setting in a number of very large trials, including the German breast group, that TILs actually predict outcome in early stage breast cancer in the neoadjuvant setting, where you're able to assess it. The patients who had TILs did better. And then if you look at TILs across the different disease subsets, you know, triple negative has a lot of TILs and ER positive has a little bit of TILs. So, you know, it really directs a lot of what we're doing in terms of thinking about the disease and what research is going. You know, it's an interesting question always. If you have a really good drug, you want to give it as early as possible because it's going to work the best. So that's always going to be the case. There's not a drug that we would sort of say, oh, we're going to hold that until you have incurable cancer. You know, we're always going to try and use the best drug earliest because you have less resistance. And we always knew that. That's not a new thing. So, you know, learning it about that this was all due to the host immune response and accumulated mutations and resistance, of course, just puts a face on what we already knew clinically, which is that, you know, as people progress, no matter what good drug you have, they develop resistance to multiple different treatments as their cancer gets more and more resistant. Right. I think, you know, it's interesting. We're looking at ways to try and explore, as a global community, ways to try and explore chemo-free regimens, because there may be groups of patients who have exquisitely chemotherapy, you know, exquisitely checkpoint inhibitor sensitive disease, or maybe ADC is that, you know, it does bring a chemo agent along, but it's really a small payload. So could it be that you would be able to treat patients who have exquisitely sensitive disease with checkpoint inhibitor and something else, or a PARP inhibitor and a checkpoint inhibitor, and you wouldn't need to really give chemotherapy? I think that's going to be a small percentage of people, and the chemo is mostly here to stay, particularly for triple negative breast cancer. I don't really know. I mean, I think that's the thing. I think that as long as you're increasing the PCR rate and outcome by even a small percentage, people are going to be very excited about it. One of the other unmet needs that we have for triple negative disease is understanding if there's a group of patients that responds better to DNA damaging agents, even PARP inhibitors. There's been assays that have been worked on that are called homologous recombination deficiency or similar. And so far, none of those tests has really definitively told us who benefits from a platinum or not. So I think it's made people largely think that, you know, these simple markers are not going to be very effective and we're going to need something else. Even though HRD in and of itself, it wasn't that simple. It's still, in the TNT trial recently published by Tutt and colleagues, it didn't predict benefit from platinum better than just having a BRCA mutation. So we know that there are some ethnic disparities in triple negative breast cancer, and in particular that we've seen in the United States that the younger African American population seems to have a higher risk of getting triple negative disease versus ER positive disease. Although overall, in any population, we see more triple negative disease in the younger population than in the older population. But I think there's a lot of concern about disparities in terms of being seen early, being worked up, getting appropriate therapy, depending on where you are socioeconomically and where you are in terms of your understanding of what treatment is available and what curative therapy is available. Because with intensive chemotherapy, more and more women are cured of early stage triple negative breast cancer as well. And I think that, education, the Triple Negative Breast Cancer Foundation, all of these things are incredibly helpful and will help to try and even the playing field, I think, in terms of what patients can receive what therapy. Well, I mean, it's incredible that we finally have a PARP inhibitor that has regulatory approval in the United States for germline BRCA1 and 2 associated breast cancer, and regardless of ER status. And that's very exciting, I think, for all of us. We're waiting anxiously to see the adjuvant data from the Olympia trial, which I think will be really important for us to understand, because the one downside of PARP inhibitors for us is that the responses are phenomenal and you double the progression-free survival, but that double progression-free survival is still short. So, you go to 7 months or something, it's like this fabulous response, but then it doesn't hold for years like we're seeing with the immune checkpoint inhibitors. Some people can stay on for a really long time. It's much less common with a PARP inhibitor. So maybe what we need to do is be treating people earlier or treating people in a smarter way. That's where the checkpoint inhibitors combined with PARP inhibitors have come up, this combination therapy, and the idea of treating patients earlier, potentially in combination with endocrine therapy, a lot of different approaches. There's a second, we have olaparib approved based on the Olympiad trial, and then talazoparib, which showed equally very good results and really nice subset data presented at ASCO with efficacy in both ER positive and ER negative disease, regardless of BRCA particular mutation. That drug we hope to see have regulatory approval in the not too distant future as well. The one thing we have learned about PARP inhibitors is so far we don't know that anybody who has wild type disease responds. And one of the interesting areas that was looked at in several different trials is whether or not something called homologous recombination deficiency actually helps us to figure out which patients benefit and which patients don't. But so far the jury is really out. It's not clear. The differences are fairly modest. And we can't be sure, other than BRCA mutations, that it's telling us much yet. It may be in early stage disease, it tells us more, where there are less competing causes for resistance, and there are neoadjuvant trials that are looking at that now to try and help. But there is also neoadjuvant data with talazoparib that suggests that a PARP inhibitor in the neoadjuvant setting may result in very high PCR rates and relatively less toxicity than some chemotherapy. So that's exciting as well. Whether or not this is going to be a treatment that works for patients who don't have those germline mutations remains to be seen. It's going to be in combination. We're studying durvalumab and olaparib at a very low dose with paclitaxel in the neoadjuvant I-SPY trial. That'll be interesting to see based on data from Lajos Pustai at Yale that shows that you can safely give those drugs together and see what seems to be an encouraging response rate. So that's, I think, really interesting. The other studies that are going on is looking at patients who have moderate mutations, so moderate risk mutations that cause defects in DNA repair. And those mutations are now being targeted with PARP inhibitors as well in a couple of different trials. So that'll be interesting to see also. We know the IOs people are using for lots of different cancers, so there's a lot of experience with them already. I think that where there has been clearly a knowledge gap has been understanding the immune toxicities from IO therapy. And so I think were 3 review articles in the first 2 months of this year just looking at what are the immune toxicities, what's the pathogenesis, and how should we manage them. We actually don't know for sure how to manage all of them. We don't know if people, for example, if they have adrenal insufficiency with an IO inhibitor or hypothyroidism, do they need replacement for life? We don't actually know if we should treat them with high-dose steroids at first and try and reduce the impact. We certainly use other sort of immune therapies when patients have steroid refractory toxicity, but that seems to be quite uncommon. As the immune checkpoint inhibitors and immunotherapy overall becomes more and more widespread, we're going to have a lot of knowledge to be able looking at these patients, particularly when they're on therapy, at least you can sort of trigger, oh, this might be due to the IO. But when patients stop the IO therapy and they go on something else, we've seen late toxicities too, not at a high level, but you see them and you have to be aware of them so you can pick them up. Otherwise, the patients really are suffering. And when we move this into the early stage setting, understanding who's developing those immune toxicities after they finish their immune checkpoint inhibitor is going to be really important.